So guests, ladies and gentlemen, friends, on behalf of my colleagues on the board of Tech Value Net, and let me reinforce Brian Gray's comments with a warm welcome to all of you for this year's event and to future events of Tech Value Net. We're proud of this National Center of Excellence. Technology evaluation in the elderly network is a mouthful. We call it Tech Value Net, or TVN for short. So we're about improving care for the frail elderly. I couldn't help but think at the introduction, the same thing with Andre Picard's introduction yesterday, there's always attention brought to where the washrooms are before we start these talks, and I presume it's because of the cathartic and the micturition impact of our talks, that you need to know where the bathrooms are before we even start. As you probably know, I'm not an expert in the elderly and in caring for elderly. And I do not have a research program in this area, and I don't do policy analysis in this area. But I am a board member of Tech Value Net. And really, from my perspective yesterday, you know, Andre, you nailed the subject completely, and I think knocked it out of the park for me. So I kind of feel a little like I'm bringing coal to Newcastle today. Maybe I'll nuance some of the remarks differently, but I have many of the same messages that you've already heard. Reinforcement never hurt, nonetheless. But I don't have any PowerPoint, so I don't have any PowerPoints, and so you might reasonably ask, why am I here? Why am I the one doing your opening plenary today? And it frankly is because I've had some past experiences, of course, in the ICU with patients of this sort, some of my own life's experiences, and I've got an abiding interest in health policy and its direction and want to be part of that. So here I am, and here we are. In terms of the directions of Canada's elderly, you know them better than I do. The demography, the epidemiology, social economics of the elderly, the spatial, financial, clinical, and societal impact of aging is huge, right? And we need solutions, and the solutions have got to bear on best outcomes, not just health outcomes, life's outcomes, as we heard yesterday. And we need to use this NCE. We need to use TVN to propel the efforts to improve Canada's aging population and what they face. So the mission of TVN is pretty clear: improve the care of seriously ill, frail elderly patients and support their families and caregivers. Pretty straightforward. But this is embedded in a much larger and a much more ambitious vision that we have for TVN, which is positioning Canada as a global leader in providing the highest quality of care for its aging population. That's ambitious. It's also necessary. So in the mission, we can see our focus, the frail elderly. But in our vision, we see our scope of what we are attempting to do. And simply put, all of you in this room, you all know one way or another that caring for the sickest of the sick elderly patient needs to start a long time before they end up in your ICU beds. And this end-of-life care that we speak of it's a long, tortuous journey. If you're fortunate, it starts with healthy aging and it ends with a good death. But it really does force us to look longitudinally and comprehensively. So as for the challenges, you've heard them all. We're repeatedly told about them. Andre mentioned several yesterday, as for instance, next year being the first year in this country that the number of elderly will exceed the number of children. The specs recently from Stats Canada and 50-year projections, where 15% of our current population is over the age of 65, it'll be more like 25%. The number of 80-year-olds, which is now 1.4 million in the country, will be up around 5 million. And right now, in this country today, we have 7,000 people that are 100 years old. We're going to have 62,000 of those. We're going to be grayer. We're going to be more culturally diverse. And more people will live in the West. And the East may wither. There, the population proportion over the age of 65 will be more like 30+%, with a dwindling tax base, as you know. So let me actually approach the challenges, and many of them, the directions that I have in mind to mention today. And in the usual clinical tradition, let me present you a case, if I might. A case of Minnie. Minnie is a mother of 5 children. She has 18 grandchildren, and she has 5 great-grandchildren, and increasing. And there's a real possibility in the next year or two that she might have a great-great-grandchild. And she visited New Zealand when she was 92 years old. Went on a business trip with her son-in-law, and this is a lady who every single week went to Tai Chi, went to seniors exercise class, until she was 96. Healthy aging. At which time she had several episodes of a facial droop and a left-sided weakness. And she lived at home with her daughter at this time, and the daughter was an accomplished physician and had expertise in chronic disease management. And so while Minnie did not have a stroke on those occasions, there were transient ischemic attacks, her cognition really began to decline, while otherwise she really continued to have a pretty good quality of life living at home. Then at age 97, this is usually the event, she fell down the stairs. And she fell down the stairs rushing to help her 86-year-old visiting sister-in-law who couldn't turn on the shower. And that fall, she hit her head, she became obtunded, she fractured her humerus, and she had non-displaced pelvic fractures, which kept her in bed. Her head CT showed what looked like a large chronic subdural, but in fact it probably was cortical atrophy, because the radiologist later admitted to the physician daughter that he hadn't seen many CT scans in 97-year-olds. Things really went downhill after that fall, and the daughter pretty well stopped practice, and with the help of her brother, she literally turned her whole home into a hospital to look after Minnie. For almost a year, her life focused on being a mother for her mother. Now, as Minnie got stronger and started to get up and around, her cognition went in the opposite direction, and she became really agitated. At times she was aggressive. She'd wander around the house, and one night she was found outside the house at around 3 in the morning. At that time, she was taking the occasional ranitidine, 75 milligrams every now and again. And that got stopped, and actually there was a temporal improvement in her cognition. But her dependence for all aspects of her daily life became progressive and became apparent, and following a Herculean effort, she was finally admitted to a long-term care facility just before her 98th birthday. There she became really agitated and was given a few doses of an antipsychotic medication, after which she was in bed for 6 days, unresponsive to deep nail bed pressure, and incontinent. Eventually all the meds got discontinued, and she improved to a steady state of pleasant demeanor, a voracious appetite, but extremely demented, and mostly unaware of her surroundings and of those who came to visit, except for her daughter, about whom she would ask every day. Time has passed, and Minnie is pretty much the same now, spending much of her time sleeping, and her daughter continues to visit twice a day. So why did I mention this case? There's several reasons. It really does make me think about the critical importance of what we so casually talk about as the informal caregiver. Those informal caregivers. This is at a time that, from my perspective, in our society, and for many reasons, we're seeing a dissolution of the nuclear family, or at the very least, pretty different configurations of what we currently consider to be families. And some people actually believe we're seeing a period of time, because of lots of different reasons, perhaps with the help of social media, that we're seeing the death of relationships. It's not the same. At least it's not the same as we've known it. So it really does raise the questions, who's going to be there? Who will the informal caregivers be in the future for seniors? And certainly, to be successful, TVN is going to have to make a contribution in this area. The case also reminds me about the impact of care of those we serve. Now, they're a very vulnerable group to everything we do in an attempt to help them. We're trying to help them, but we often hurt them. It's standard practice when seniors come into an emergency room, particularly if they're obtunded, slip a catheter in their bladder. Makes it a lot easier. They don't get wet. And then you start the cycle in some of them of urosepsis, and in some of them they actually end up in his ICU and they die because of a bladder catheter. A catheter in the bladder of an elderly patient can be seen as a high-risk intervention. Usual food and fluid restrictions that you might use perioperatively really don't make sense for them, and a little goes an awful long way when it comes to medications, the vast majority of which we have no idea how they work in these elderly patients because they've never been the subject of any testing in that age group, and certainly haven't been tested with the multiple meds that they're on at the same time. TVN's got to make a contribution in this area. The case also thinks to me about where all of this is going in the big picture, such as Andre talked to us about yesterday, and when one looks beyond Minnie to the ever-increasing number of frail elderly, just like her, on her own ward, and really across the country. The big picture. TVN's got to make a contribution in this area. Gets me thinking, as we discussed yesterday, we're not talking about this the right way. We're not talking about the elderly and aging and its consequences the right way. Michael Gordon, who's the palliative care medical director here in this city at Baycrest, said, watch your language. Watch your language. The gray tsunami is dangerous metaphor. Don't use it. Don't say those words. Gray tsunami. Dear God. As Andrea Charisse, who's an assistant professor here at U of T, said, quote her, is the progressive aging of society really equivalent to the instantaneous devastation of cities? Is that what we think? Andre said yesterday, we have 50 years to get ready. We've been hurrying up to get ready for 50 years for the baby boomers. And now it's a tsunami? Wrong way to think. Wrong language. We know why these terms are used to get people's attention, but there's a clear and apparent downside here. Really serious downside, because this kind of language really contributes to ageism. You know, frankly, if the elderly are as dangerous as a tsunami, then, you know, why would we improve their quality of life or want to keep them around? Let's just retreat. Let's go to the high ground, right? Let's just get out of the way. Obviously, this population is going to harm us. Well, if you use that line of thinking, that might run a serious risk of all this. We talk about goals of care. That could become a prescription for therapeutic nihilism, where somehow or other you make a sense of justification of not treating patients better than you do because you think that's what they want. So be careful about ageism, because it might really completely destroy the validity of care for the elderly. So I'm reminded that our language really does matter. And for some of us, remember, those are your parents you're talking about, or your grandparents. And in fact, for some of us, it's now. So, you know, perhaps for me, I need to develop more personal expertise in healthy aging, probably. And maybe I could get John or Deborah or Margaret or one of them to do me a synthesis on all the world literature on healthy aging. I might pay a bit more attention to it, and I could get it next year for my 65th birthday. That'd be good. Now look, because of the kind of audience here today, let me mention a challenge that really, really bothers me, persists for me in my own mind, and it has to do with this longitudinal trajectory that I've spoken of, long before patients end up in your ICU. Canada has a real problem looking longitudinally. And it's true for healthcare, social statistics. It's true for aging particularly. We're challenged by being able to look longitudinally because of the data. What data do we need to make a difference in the lives of seniors over time? Well, there might be lots of specifics, but what we actually need is person-specific longitudinal data. People over time. And that's got to be able to be linkable to education, social, labor, income statistics to get a clear picture, to model the future, to get a better idea and improve the understanding of how we could plan and implement changes. That type of data is not so arranged in Canada or simply not available. For the researchers in the room who know as well as I do, longitudinal surveys and cohorts are rapidly becoming extinct at a time when many of us notice exactly what we need or ought to be doing. And at the same time, we're losing our ability to do small areas analysis, as you know. Data that is necessary for looking at disparities and opportunities for local area improvement. We're losing it. And if you think the Canadian Household Survey, with a non-respondent bias as it has, we got about a 60 to 70% response rate, and ain't anything like the long-form census. And why have we lost our ability to look at small areas analysis at the same time we're losing our ability to look longitudinally? At the time that you think you want to know a bit more about the trajectory of aging and how to influence it, this is a serious problem. And, you know, not surprisingly, what's happening in the conversations I'm finding myself in particularly is that there's a sort of almost a policy direction now towards maximizing the use of administrative data. Let's use administrative data. That's okay, we'll just plug the holes, no problem. And that will have to be a policy area that we do have to exploit, because the richest source of that individual health microdata for sure is in the provinces. In fact, lots of it is in non-linkable sources, like physicians' EMRs, as an example. And there's very few places in this country where the information from a doctor's EMR feeds the electronic health record of the patient. Wow. How cockeyed is that? I mean, really. We're getting close to almost, 15 years sort of info away? And we're rushing to the bottom in EMRs. So these policy challenges are pretty apparent, but our response is awfully attenuated as we struggle towards being at the bottom of the OECD, like I just said, with respect to electronic health records. How can that be? We're down there with the United States. So are you at all surprised that we are also at the bottom in the OECD countries for transitions of care? If the information doesn't follow the patients, how could you have good transitions of care? So do you understand right now that in this country that a doctor might see a patient tonight in one of the emergency rooms and has no idea whatsoever that they saw a doctor yesterday, whether it was an emergency or not? You might not even know the event took place. You might find out if you got the history from the patient. Could you have asked Minnie when she showed up in Emerge? So how can that be that we don't know what meds the person was on, what interventions they got, what the damn diagnosis was yesterday? It's 2014. We really got to do better than that, and we can. I'm going to end my stream of thought here, but I got to go back to the workshop yesterday. That made a big difference for me, and Joyce, thank you for doing that on behalf of the board. I want to talk about this focus on elderly citizens, the person, and person-centered care. No question is values-laden, right? So think again perhaps about Minnie when she was healthy, her journey through cognitive decline, and through end-of-life care. We know there are a lot of challenges here, and whether or not you want to call them a deluge or not, this is really a universal and it's a societal challenge. And so in the community, I think that this means that we need policy and practices that promote something that I hope you're not offended by, the notion of the medical home. Every elderly person in this country needs a medical home, particularly the frail elderly. Now, in the ideal, for me, let me describe my vision of the medical home. What would my medical home look like? And to build on that metaphor, what location would it have? Would it be in a larger patient-centered healthcare neighborhood? So the medical home, you probably are quite familiar with the term, would offer me some fairly definite attributes. What would I want from my medical home? I want a relationship with a doctor. I want a team. I want expanded access. I want comprehensive and coordinated care, and I want to feel that I'm getting quality and safety. That's what a medical home is. That's what would embody the attributes no matter how it was configured. Now, my personal medical home is situated in a conceptually broader, patient-centered neighborhood. And the neighborhood has to offer me expertise beyond my medical care. Medical care is necessary, is not sufficient, often is not even the necessary part. But beyond medical care, we need other types of care in that neighborhood. And here's where the health-related data has got to follow the patient. One patient, one record. That doesn't mean one vendor, just one patient, one record. Not many places in the country got that. That's what you need. So in that medical home of mine, that's where my medical data would exist. And that trusted source of medical data in my medical home is linkable. It's linkable to other data. It's linkable to data which might give me my caregivers and researchers other information around me. Because the more they understand about me and the sample of people like me, the more they can have effect on our population. And we get better practice and better policy. And I don't have to lose my confidentiality in the process. I'm fed up with people waving the Health Information Act at me as the reason why we're not improving people's health and health care with data. I'm tired of it. And there's no reason whatsoever confidentiality has to be lost in an environment of common sense, linkable information with modern day technologies and approaches. Because you see, I want that data to help populations like me. I want continuity of care, really. You know, I don't want to be doctor shopping, and I don't want to have a different doctor for every body part, right? I don't. You don't either. I really do want to be asked about my care. I'd like to know that there were some options, and I'd like to have a reasonable shot of believing that the person who was telling me this was basing it on the evidence. So, in bringing our challenges to more specific directions, let me close off by talking about a few things that we're doing in Alberta and Alberta Health Services in relationship to seniors and their health. Now, as you know, Alberta in 2008 and created a different system. One system for the whole province, and it's still a work in progress. One of the things that we're doing in the province is establishing strategic clinical networks, SCNs. Get used to the terminology, you're going to hear it more. Strategic clinical networks are SCNs. We have one now for seniors' health. The Seniors Health Strategic Clinical Network is one of 10 that we have in the province, and each one of our networks is focused on a population of interest and is meant to take a broad view from determinants to end-of-life care, and it's about driving clinical change. Networks are about trying to improve the outcomes of patients. And we have one, as I said, in seniors, and of course, Duncan Robertson is the Senior Medical Director, and Jana Holloway-Leduc is the Scientific Director. We have a Scientific Director for each one of our networks to ensure that they're evidence-based and ensure that the research and the KT agenda is alive and well associated with measurement and a desire to change outcomes. So some of the things we're doing right now have had an early success in reducing antipsychotic medication in long-term care facilities, 11 adopter sites. We found initially prevalence in some of those sites in the order of about 38% of the people on antipsychotics is now in the order of 20%. Now, can we sustain that? And what are the consequences when you reduce the antipsychotics? So far, it looks as like they don't wander away anymore. Falls haven't gone up, nursing hours haven't increased, and maybe the families are a little happier, but the patients are not as cold-cocked. And that's a good thing. That's a really good thing. When you visit and you don't get any response, it's pretty hard on the so-called informal caregivers. Now we're going to scale this idea of getting rid of the antipsychotics to the extent possible up to 160 facilities, because in Alberta now we have some possibilities of doing things province-wide. So watch, let's see if we can get it done. But other areas we're advancing is perhaps a dementia hotline now linked into HealthLink, which is our province-wide dial-up service, 24/365. A dementia hotline, perhaps as the top end of a dementia strategy, which is in formulation right now in the province. Still not developed, but that's what our aspiration is. Actually, I heard that all the ministers got together recently at the G7 to talk about dementia. So I suppose the dementia strategy for Canada is coming soon. Is it? Where's the dementia strategy for Canada? Let's not just go over to G7 and talk about it. We really need one. So just in case Canada doesn't, Alberta's going to get a strategy for dementia, and we all need one. So there's a number of different things like that that we are working on in the Seniors SCN. There's a few things that we've got in mind, too, based on some of the things we heard yesterday. The elder-friendly hospital is a no-brainer, right? Let's just do it. An elder-friendly hospital. What would that look like? And inside that hospital would be an elder-friendly surgical unit. Ooh, what would that look like? I think you could paint that picture pretty well. Remember the catheters, the food, the fluids, the meds, the ambulation, tuck-in rounds. Just imagine a bundle of care that was evidence-based and focused on the best interest of the elderly and tied it in a bow with tender loving care, right? We treat the elderly like everybody else, and they're paying a price. So an elder-friendly hospital would have a completely different philosophy of care. And when I got into that surgical unit, I'd kind of probably feel special, and I'd be treated differently. It would take into account the physiology of the elderly and the evidence base about how we get them through the perturbation of hospitalization with the least harm possible. So finally, to deal with those transitions of care that I mentioned as well, and one of the things that we're going to work on is a comprehensive evidence-based care pathway for certain and particular challenges like dementia and cognitive disorders. Care pathways, the full journey mapped. And it's got to be an entire coordinated journey. It's got to start with health determinants way back in the early healthy aging days. And it's got to move through healthy aging with strategies and actions to retain it, and then it's got to go through cognitive decline and support for it all the way to the end of life. These are hard to build and to operationalize. Other places have done this. Lots of other places have done this. Now we need to for selected parts of our case mix as well. You see, it's not death that you're trying to improve. It's the dying process. Death is death. Dying is tough. We don't even talk about it, actually, which is interesting. TVM's got to deal with that. So I hope I've touched on some of the issues that you have on your minds and some of the parts of your work, and forgive me if I trivialize some of these issues and directions, challenges. You know, I'm starting to come by my ignorance more honestly now, because I'm influenced perhaps more these days by life's experiences and the stories than I am by the evidence. And I would close by simply saying I'm really grateful for being part of TVN and being part of this board and my colleagues, because I know that every one of them is really, a thoughtful person, and we're trying to take a long-term vision here. And we're attempting to realize that vision through communities of interest just like this. We're really thankful for the NCE program. Glad to be part of it. And the board is grateful that you have come to this event, and we want to continue to see you coming to these events and participating in building up this community of interest. We're all indebted to Darren Hyland for starting this, and we owe an enormous amount of gratitude to Sharon Carstairs for nurturing this into existence, and now to John and Carol for keeping this thing going. And it's real. I'd like to end on just a comment again on the case presentation, if I might, because I'm most grateful to my beloved mother-in-law, Winnie. She's taught me more than I could possibly imagine about the elderly. And with editorial license, of course, Winnie is Minnie, and Minnie is Winnie. And as for Winnie, who makes me think about these things quite a lot, in 113 days from now, she's going to be 100 years old. And I want to spend that birthday with her. Thanks for hearing me.